That makes one of us.
That's funny because you're in technology. Oh, here it is. Okay, wait
Kind
a
of.
minute. Did it work? We are on air. Woo! Okay. What's up, everybody? Obviously, Christy still has FCA National Brinks. I'm like, I can't go live, and here we are. I am super excited. I told y'all last week that I just could not wait to have this week's presenter here. Dr. Brandon Steele is with Chiro Up. Um, he's a chiropractor, graduate of Logan College of Chiropractic, which we just talked about while we were waiting for all of y'all to join us today. Um, he has been in private practice in the St. Louis area for how long have you been appearing live and in person? We were just talking about how his game on the stage is way higher than mine because he can hang out for like 8, 10, 12 hours. Christy's got like a 4 hour max. But one of the things that I really, really love is that you're like, it's not just about like chiropractic technique. You're so into the business side of growing your practice, and you're really into the technology and the marketing and creating a really dynamic patient experience, which all of that plays into the success of a chiropractor. You can be an incredible adjuster, but it's about your business too. And so I think that's just one of the great things that I love about Dr. Steele. And it's really funny. I've known about Dr. Steele for a really long time, sat in his classes, and we were in Las Vegas, and I have this wish list of webinars.
And most of it was true, which is always good. So first off, thank you. Before we get into the presentation, thanks for having me. I do enjoy doing webinars and speaking, and it's and like we talked about, it's just fun to do when you can find people who believe what you believe, and you can find people who are as interested as you are. Then it makes it really interesting to have those conversations and learn something every single time you get out there and meet those people. So I think we have a presentation here right there. And Christy, can you see my screen?
I can see your screen.
Perfect. So we're going to go ahead and get started. This is my favorite talk of the year. I've only given it twice, actually, which is it was as part of a longer talk. It's kind of whittled down. If for those of you who don't know what ChiroUp is, we just take the research and we turn it into bite-sized pieces for chiropractors and also their patients. So one thing that I always find interesting is when I meet a chiro who's been doing the same thing for 10 years, and they do the same treatments for every single patient. I'm always intrigued by that person because I have a very different personality. And out of that erratic personality, I develop a company to kind of learn more and to kind of be on the cutting edge of where research and practicality lives. Because just because it's in a randomized control study doesn't mean we need to do it in our practice. However, we need to look at those things that we're starting to find come out in the research, and not necessarily what treatment is best or what exercise is best or what evaluation is best. And we're going to cover those in this hour. However, how do we apply those things? Because the simple fact is, when it comes to patient care, I get paid to do two things, to evaluate and manipulate. Now, based on your state, it could change if you have other things you can do, but I've got to be really damn good at doing those things. And I've got to be quick and efficient and effective at those things. So anything that I can find to validate what I already think I know and what I already do, I'm always excited. However, people don't see me just for neck pain and back pain. They see me for a plethora of issues, whether it's carpal tunnel syndrome, whether it's rotator cuff syndrome, or Achilles tendinopathy. I need to be well versed in how to assess and how to treat all those things. So we're going to look at a lot of different things, 10 different diagnoses, 10 different thought processes, and provide some new thoughts. 13 years ago in school is not necessarily what is definitely taught now. So I think that when it comes to manipulation and what we do, there's a ton of research in the past, and more so now, that shows how safe and effective what we provide. However, manipulation is not best practice management or anything. However, it's included in best practice management for a lot of things because of the safety and its effectiveness. So my question to myself was, okay, so when should I use it? When should I not use it? And school did a pretty good job of teaching me how to do that. However, what else can I add? Because people don't have a lack of manipulation in life. They have a problem. They have arm pain, they have shoulder pain. And while I can use manipulation, what I found is that those tools, those methods by which we treat, which is dry needling, manipulation, exercise, manual therapy, advice, those are powerful. However, it's really the people that understand the principles of what they're trying to accomplish with their patients that make all the difference. And those are the people who can say, we need to rest and relax this diagnosis. We need to do eccentric exercises, dry needling and manipulation, or maybe we just need manipulation and some advice on posture. It's those people that are the greats. And I want to learn from them. And so today's talk is going through some advice and some things that I learned from providers. We have about 2,400 providers around the world that we learn from. And then we also have PubMed. We put out about 300 articles a month and new research. Then we try to boil it down into infographics and evaluations and exercises so we can turn that into patient education within seconds. And we came down with, for 2022, 10 things that really were game changers. And the first was, this isn't necessarily a skill. However, there's a lot of good research and research by chiropractors that have helped us, helped our profession, and helped me in practice, help deliver pertinent information to my patients, because here's what they are hearing. Our patients hearing this all the time. Is it like chiropractic care? Do I need opioids? And the simple fact is that this isn't the right argument. That realistically, we have opioids due to a lack of chiropractic care. And I think that we have an epic failure in healthcare that unfortunately has led to an opioid crisis. So research like James Weeden have looked at what are the side effects, what are the costs, so what are those things that are associated with good care. Good care is when a practitioner says, hey, here's what's going on, here's what we're going to solve it. And care that is more, I don't really know what's going on, try this drug, try this brace, try whatever it is, because most of our chronic pain comes from acute pain that was never dealt with appropriately. And what we know is that when that happens and we select a chemical to fix a mechanical problem, like musculoskeletal pain or neurologic pain, that's not a good solution. And we have to accept the consequences of that, because if you choose a very ineffective, costly, with a lot of side effects option, here's what you get. So unfortunately, those adverse drug effects with selecting the opioid is significantly higher because you're not attacking the right etiology. We also know that if they see the right provider who can attack their problem and get to the root cause, which could be the way they sit at their desk, the way they throw a baseball, the way they sleep, and then attack it with highly effective, highly safe strategies like manipulation plus manual therapy, like manipulation plus manual therapy plus exercise, we can get the best effect for these types of patients. And if they don't see that kind of provider, then we have issues. And the issue is poor, ineffective care. So that's where I think that the schism will happen with a lot of the providers and the people in our profession, is who's getting the best results. And what we know is that when you use a result like this, and obviously that's not our profession, it's just not very cost effective, and that the patient pays the price. And Weeden put out almost all of his papers in the last 2 years have been tremendous. This one is going to change the way we're reimbursed, to be honest with you, because what we know is the short-term effects, the short-term cost of receiving manipulation is actually higher to see us versus taking a white pill. However, the long-term effects is drastically different. If you select chiropractic care versus an opioid, the costs dramatically go down because it's a more effective care. That QR code small. We have infographics for everything that we do. So if you guys see anything in this presentation that you want, email me, Brandon, BRANDON at ChiroUp.com, ChiroUP.com. Be happy to send it over to you. The way I look at it, if you repeat yourself more than once in a day, if you have to keep on educating your patients on the same thing over and over again, I use digital means of solving that problem to kind of speed you up in practice. This is one of the infographics that I use for my patients. But what we know is not even just opioids, but if you take a steroid, a non-steroidal, while that may give you some short-term relief, it actually makes the back pain worse. So we're finding that it's not just randomized control studies, it's our systemic reviews, our meta-analysis saying that we've got to just do a better job with patients. Now, there is one side effect of seeing a chiropractor, is that our patients are very satisfied. And that's not an opinion. We can look at this article in JMPT, but also we did a study over the last 18 months of 680,000 condition reports we put out across patients around the world. And after 30 days, they rated the care of their provider. And it said, hey, Sally, we saw Dr. Smith. How many times you see him? What % better are you? How satisfied are you with the care? And on a 0 to 10 scale, how likely are you to refer this practitioner to a friend? So out of over 680,000 diagnoses put out, 92.7% said their care they received after 30 days was excellent. Nearly the rest of them are good. That's just unbelievable. So patients love what we do, but if you look at the future success of any healthcare facility, look at the NPS score. And that's that last question that I said. Listen, Sally, how would you rate this provider? If they rate you a 9 out of 10, they're excited about the care they received in your office. If they rated you an 8 or a 7, they're okay with it. They got there what they expected. And anything less than that is a detractor of your practice. And the amount % of promoters minus % of detractors gives you a number somewhere between negative 100 and positive 100. Now, if you are a face-to-face provider or any kind of a business where they're dealing with a person, 30 is pretty good. And that's where most MDs fall. A world-class organization like a Four Seasons, they're at about a 60. Can you guess where chiropractors fall in that? 90. Tremendous. 89.8. I round up. That's crazy high, meaning patients love what we do. And I think with studies like Whedon and clinical information like the next 9 skills that I'm going to show you, if we can continue to get good results, good clinical results, and then we can market those clinical results to the people that matter, which are researchers, which are insurance companies, like it or not, legislators, then I think we can have a dramatic impact on our profession, obviously in a good way. So the rest of these, that's kind of a filler. That's more of a feel-good message that the research is out there and what we do, not just opioids, but manipulation. The rest of these are going to be based on just clinical skills. That's where I live. I love getting people well. And I'm always looking for an edge. How can I get more people well? And the number one thing that I look for is those little clinical pearls, those little nuggets of information that if I can find that one thing that's causing this person's problem and I can help take that problem away from them, I've gained a patient and really a friend for life. And you guys have practice like I do, that I'm fully invested with my patients. And I think that if I can truly be empathetic with my patients and I can really dig into their life and kind of see their problem from their point of view, then I can hopefully try to weed out the nonsense and get to that etiology behind their problem. Migraines are one of those that it takes a little bit of a clinical hat, a little bit of a wizard hat sometimes to find out what's causing these problems. So there's 3 things that I learned in 2022 that are significantly helping me in practice. Now, I'm not a supplement person. I'd rather change your religion than change your diet. I just don't know how to do it. I'm not that kind of chiropractor. However, I have a functional medicine chiro that I work with in my area, and I send all my patients to her. And guess what she does? When she has someone who has an MSK problem, she sends them back to me. So finding people who are great at what they do will be tremendous for your practice. And obviously, most importantly, your patients. And what we know is that vitamin D works. Now, there's 2 ways to get vitamin D. One, supplementation. There's a ton of research. This paper says 2,000. I've seen it as high as 8,000 IUs per day. Remember, A, D, and K are fat soluble, so we don't necessarily want to load people up too much. However, what we're finding is you can really use a lot more than the standard recommendation. The other one is kind of like a dating app. It's called Go Outside. And as you know, with your patients, sometimes it's difficult to get them to exercise and go outside. But if you're not able to get outside, then supplementation seems to be the best diet, best remedy. The diet is the next one. This paper is tremendous. This was a paper in the British Medical Journal. Journal of Nutrition. It came out in 2022. That you can reduce the frequency and severity of migraines by 50% just using this diet. Now, this is pure opinion. I eliminate the grains aspect of it. I have my own personal reasons. However, this is a great way to help people. It's a structured way. There's a lot of people that say take out dairy, take out grains. I'm fine with that. You're the provider. However, following just this diet can help get people better. And I find that with diet, it's more about just being committed to what you're providing, and being committed not to eat the very unnutritious food. And lastly, manipulation. And now there's one big key here. And the key is not that manipulation is going to ease the intensity of the disability, the medicine intake, and also increase quality of life. Obviously, that's tremendous. We see that when we read the abstracts of these journals. However, here's a clinical pearl that I honestly, in 13 years, did not know. And that is that manipulation is not a good abortive therapy. I'm always intrigued that I've got some patients who I manipulate and their headaches go away. And I'm like, well, I go cut off the tags on mattresses. I buy my kids ice cream. I think I've got magical hands. And I'm just walking on clouds that day. And then I've got some patients that I manipulate does nothing for their migraines. And I manipulate them once or twice. I'm like, well, maybe I'm not the guy for you. Maybe you should try someone else. Well, as it turns out, I'm not being, patient enough with these patients. That manipulation does ease those things with migraines, and it's a great prophylactic treatment that we need to be treating them a couple times over the next month to see that effect. So I've really changed the way I've practiced, and also my patient education to say, hey, you may not just walk out of here without a headache. However, let's treat this twice a week for the next month, and let's see what happens to that frequency and severity of migraines to see what that true effect is. And keep in mind with migraines is that it's not just manipulation. There's many etiologies to migraines that just applying manipulation to all migraines probably isn't going to work for everybody, but it may work for some. Just working on nutrition may not work for everybody, but may work for some. So let's not dig our head in the sand and say, this is what I provide. Instead, just because we don't provide it in our office doesn't mean that's not what they need. We just need to find the right person for them. Also keep in mind dizziness, and I'll go over that. I think it's half of people with neck pain have dizziness. The number is a little less, it's in the 40s, but that's crazy. So we can start to have someone come into us with one problem, but maybe we should be looking for a different etiology. The same happened with jaw pain, sharing the same neurologic origin. Now, here's something that I preach on. I'm very fortunate to go speak at different associations on a fairly regular basis. And I'm one of those people that I don't think we should be evaluating people through advanced imaging and x-rays on every visit. However, with that being said, there is a place for it. Absolutely 100%. However, what we know from the research is that in the absence of red flags and in the absence of trauma, that there's no correlation from function and pain, and there's no correlation between structure and pain, which is crazy because all I do all day long is assess structure and function, and my patients have pain. So I'm not saying those things don't matter. It's what I do. But when you can marry imaging to an orthopedic exam, and two, does the joint move properly, then we can start to piece together those pieces of the puzzle. Here's one study that I learned that is kind of proves me wrong, though, is that the presence of Schmorl's nodes is associated with neck pain. And so we dug a little bit deeper into that, and I'm going to show you kind of fun slide that Dr. Burrows and myself put together, because we're trying to think about why this is the case. Why is it just presence of Schmorl's nodes? What about a disc problem? What about stenosis? Why are those not associated, but a Schmorl's node is? So if you take a look at the typical Kirkland-Lewis phase of degeneration, and we have we'll call it a bucket of water, but really it's a bucket of water with some proteoglycans and glycosaminoglycans stuck in the middle. It's kind of like Legos in a bucket of water. So if you put a bucket and you put half Legos and half water in the bucket, and you slowly put your foot in the bucket, you would probably be able to get to the bottom of that bucket and be just fine because the Legos will slowly move out of the way. However, if you took your foot and jammed it down in that bucket, those Legos would form a nice brick and you would scream out a bad word. And the same thing happens with discs because discs are non-Newtonian fluids because of that protein matrix they have in them. So when you slowly move a joint, it's almost like a fluid. So if you stay in a prolonged posture for a long period of time, that fluid's going to want to weep out in the opposite direction. But if you quickly load a disc, what happens? It turns into a brick, and now that material shoots through the cartilaginous end plate. So it's interesting when you look at the phase of degeneration and why we have pain is that fluid and that structure, that water structure starts to lose its fluid. And we find this because of lack of motion. So one thing that we do is we find those joints are not moving properly. And those joints, if we don't get them to loosen up, unfortunately, they're not getting exchange of fluids. and that matrix starts to degenerate or change in its composition, and it creates a sloppy joint. Now, because once you start to lose fluid, those two bones sitting on top of each other starts to move a little bit more, have some accessory ranges of motion, a translation, and we start to get those patients that have a hitch when they're giddy up. They start to have a painful catch. Those are our facet joint pain patients, because unfortunately now those back joints, the facet joints, are rubbing into each other. Over time, that disc, the outer third, is going to start to get weakened, where those circumferential tears are going to start to move closer and closer out into the lateral recess. And now we get symptoms like radiculitis, or these are our disc lesion patients. These are patients that respond to directional preference. If we don't attack it properly, now that disc material is going to go all the way out. Those tears are going to coalesce. And unfortunately, now we have a chemical problem, because that fluid now weeps out into the neural canal, and a massive inflammatory reaction happens. If it heals, possibly, or if it doesn't go into a full disc herniation, we start to see this vacuum phenomena where, unfortunately, that disc is starting to degenerate so much that cartilaginous end plate no longer sticks to the ends of the disc, and now we have a problem with fluid going up into the vertebra or down into the disc. And now we just have a typical joint that the three parts, the disc and both the facets and the three joint model, are going to start to degenerate. And this is where most people live. We have them in this arthritic phase. And unfortunately, this leads to our stenosis, and this leads to the problems they have. But it starts with lack of motion. So it kind of shows us what we do is so important, because if it goes so far to cause those Schmorl's nodes, unfortunately, they're going to have problems. And now they have a mechanical problem that's probably not going to fix itself. Here's good. Oh, it's got Dr. Burlesman. I apologize for that. Thought I cropped him out there. But we took a pig spine and dissected it, and then took a look at it. Well, what does the actual nucleus look like? And what we find is that, unfortunately, that due to that lack of motion and due to that fluid not being exchanged, the disc loses pressure. And the outer third of the disc has nerve fibers, but when it loses pressure, now the blood vessels and also those nerves can go into the disc, and now we can start to feel pain within the disc. So it's all about pressure, and the pressure has to do with range of motion. So doing what we do with assessing joints that are not moving properly and getting them moving makes all the difference. But don't forget about the other things that patient may need. It's not just manipulation. One of the things with degenerative changes is to get things moving, which is what we do so well, but it's also to keep things moving. And things like inversion tables, things like exercise at home, all those things are tremendous when used appropriately. Also, when you look in the research, we're seeing a huge, just crazy amounts of research coming about neurodynamics. Using nerve sliders, using nerve tensioners has been, it's been a focus of research. And I'm always intrigued when people treat sciatica or treat carpal tunnel syndrome and they don't use neurodynamics. It's something that we teach in our classes nonstop. And I'm shocked by people who don't use those, because what are we treating as chiropractors? Yes, we're treating the MSK structures. However, we need to get those nerves moving. Nerves have to move just as much as the muscles and the ligaments sometimes. They have to slide through the intervertebral frame. They have to go around bones. They have to go through muscles. So we can't just think about things as muscles and ligaments and tendons and joints. We also have to think about what's also causing that pain, and it could be a nerve. Michael Shacklock's book, Clinical Neurodynamics, is tremendous. Learning how to do nerve dynamics. I think that's something that, as chiros, we should all be at least looking into, to add a new tool to our toolbox. I didn't mention this before, sorry. If you guys have any questions, throw them into the question box, and I'll get to those at the very end. Questions are really what these webinars are all about. So, if we leave this webinar and it's, let's say, Tuesday, and we didn't do anything different on Wednesday, well, then it's a waste of our time. So if you learn something, or if you have a question on something, and you want to be able to utilize that, please let me know. I'm here to help, and I'll hopefully try to convey some fun things that I learned this year, and hopefully help them add to your practice. This is the dizziness stuff. So I'm always intrigued when patients will get off my table and they're sitting up and they're dizzy. I'm like, oh, you have some dizziness? Oh, yeah, it's been going on for a couple of years. And there's two types of chiropractors. The first one's, oh, let me make sure you're safe. Let's get you up and get you out of here, which is ridiculous, because BPPV, or cervicogenic vertigo, is something we should be treating also. So obviously vestibular problems are not MSK. However, the treatments really are movement related. So we have a huge population of patients who have vertigo that, instead of just helping them off the table and do that. Don't let them fall over. However, we should be now assessing for that problem. The patients come in to see us for a condition, and that's all they think that we treat. If we can now convey to them that we also treat plantar fasciitis, BPPV, rotator cuff syndrome, that's when we can start to scale our practice. Kind of like Christy said at the beginning, that when I first came out of practice, the only thing I treated was actually pain and pregnancy. I worked at WashU over in St. Louis, and I worked in the pain and pregnancy clinic. That's where all my patients came from. And I thought I was pretty decent at that. Everybody talked about me, and that's where I got my patients from. And then I was like, I took a class in TMJ, and I was like, oh, that sounds really interesting. I'm going to start working on these patients. And then I marketed myself to dentists and oral surgeons in the area, and I started working on that. And then you're a chiropractor, so most people see you for neck pain and headaches. You can't, as a chiro, you can specialize, and that's tremendous if you can. However, we have to be good at all those, because people are going to have random problems on a daily basis. The question is, how many of those are you educated enough and readily available to treat and to evaluate? Because when I see this kind of number, I see a ton of patients with neck pain. I'm sure you see a ton of patients with neck pain. That if they have neck pain, then yeah, dizziness is a component of that because of that neurologic connection in the brainstem. So making sure that we attack that. Thing is, now this is for cervical general vertigo, not BPPV, but what do they need? They need manual therapy. They need manipulation. Those are the things that we provide in our office. And unfortunately, if they get shuffled into a different office, or I don't address that with my patient, they're going to talk to their primate. They're going to talk to their neighbor. They're going to talk to Google, and they're going to find a solution for them. That solution should be us. One test that, and I don't have it in this paper or this presentation, but the head fixed body turn test will help identify, does someone have BPPV or cervical general vertigo? Quick test, you hold their head and have them use a roller chair to roll side to side. And when you eliminate one of the variables, meaning head motion, you can help identify, is this dizziness coming from a cervical structure or a vestibular structure? Also, one lesser known exercise for BPPV that works for that anterior canal, the most common cause of BPPV, is the Foster half somersault. So take a look at that. I don't know how you guys deliver exercises, but when it comes to BPPV, you need a great recipe to help get these people out of the problems. And the Foster half somersault is probably my favorite. So something else to consider. Tons of research on both of those. Now we're going to dive into two topics in the shoulder. The shoulder is my favorite to work on, and because it's unique. And it's unique in the aspect that most of the things that we treat are based on getting things moving, restoring motion. But when it comes to the TMJ, and it also comes to the shoulder, these are crazy mobile joints. They don't need mobility. In fact, they need stability. And when there's a breakdown in stability, that's when bad things happen. So instead of going through and mobilizing stuff, and there are some things we have to mobilize, certain directions of motion. However, the vast majority of their treatment is actually stabilizing them, which is more exercise. But what we know with the shoulder is that when there's too mumuch range of motion, remember that the glenohumeral joint is a ball sitting on a flat surface, which we call the coracoid. It's got a touch of concavity, a couple millimeters, but essentially ball, flat surface. It's the rotator's cuff's job to help pull that ball down. But if the rotator cuff doesn't pull that ball down, there's a hard thing sitting on top, that being the acromion. And there's a reason we have that coracoacromial ligament, which is a ligament that attaches a bone to a bone that are also attached by bone. It's not because those bones are moving apart from each other. That's the top roof of your actual glenohumeral joint. And we need that stability. So when people start to remove that acromion because they have a rotator cuff problem, they're really setting a person up for unfortunate second surgery where they have to do a prior reverse shoulder. But the purpose behind this paper is that don't forget about the subscapularis. That you and I, depending on the way you adjust, I spend all day over my patients with my hand on their lumbar spine or SI joints and dropping on them and getting joints to move, if applicable. There's one specific muscle that's preventing my glenohumeral joint from shooting through the wall behind me, and it's a subscap. It's got a great line of pull, so this is something significant to you. And unfortunately, if we don't, I just use the laser. Obviously, you guys can't see that, but if you move the glenohumeral joint up, and unfortunately, what happens is there's squishy stuff in the middle, and that supraspinatus and that bursa pay the price for that. So here's a little known fact that I want hopefully everybody to appreciate. is that there is one range of motion that is normally lost with our patients with their shoulder, and it's inferior glide and also internal rotation. So when that ball rolls upward, if it just rolls up that joint, it's going to hit that roof on top here. That can't happen. There's squishy stuff in the middle. That supraspinatus isn't going to enjoy that very much. So as soon as you get through 22 degrees of rolling upward, when we start to pick our arm up, we need this joint to also slide downward. And if we can do that, and we can, as chiros, as manual therapists, we can help force that inferior glide. It's going to be tremendous in freeing up that subacromial space and allowing that person to have purposeful movement without having pain. So working with internal rotation and working with inferior glide of the glenohumeral joint can help your patients get out of pain. Now, obviously, manipulation does a tremendous job also. People have pain, they have problems, those muscles start to shut down. Manipulation helps take away pain, help get that thoracic spine into extension, to get that shoulder blade back into retraction, and it's going to help improve the function of all those muscles and also improve the subacromial space. So we need thoracic spine extension, something to consider with your patients. And if you can do that, along with the other stuff that you can do for, in this case, shoulder impingement syndrome, working soft tissue manipulation of the glenohumeral joint and internal spin, and also the cervical and thoracic spine, along with doing these exercises, we can really make a dramatic impact on patients. And a lot of our patients have shoulder problems. It's actually the number 2 diagnosis behind the lumbar spine. This is a big piece of the pie. A lot of your patients have shoulder pains and problems and aren't telling you about it because they don't know that's what you treat. So please don't just do manipulation. Don't just do manual therapy. Don't just do dry needling. Don't just do eccentric exercise. Find the right recipe for the right patient. And that's one of the things that I think is crazy easy to do. With technology now, we know what best practice management is for shoulder impingement syndrome. And with Chiro, we have 150 diagnoses that tells you, here's the evaluation, here's the treatment, here's the exercises, here is now the piece of paper and the exercise to give to your patients. Make it simple for them. You can't give them 37 things to do. Give them the 3 or 4 simplest exercises. Provide the most effective treatments, including manipulation and manual therapy or nerve flossing. Get them out of their problem quickly. I'm always intrigued by this. Obviously, rotary cup syndrome is not a real thing. However, that's what people call it. You can even Google rotary cup syndrome. It's actually rotator cuff syndrome, as we all know. However, here's the tidbit that I want everybody to know. There is a better way to assess the rotator cuff. That I learned the drop arm test. I learned empty can test, O'Brien's test. There are better tests now to identify rotator cuff problems because this paper right here, people can pick up their arm all day long, pick up grandchildren, and you'll never know they have a rotator cuff problem. But if you do the most specific and sensitive test, you can help weed these things out and prevent them from being a bigger problem. The number 1 test for the supraspinatus, the most common muscle is torn, is the dime test. Having the person go all the way up in the scapular plane and also in the frontal plane, and then resisting their motion as they go down. You're looking for pain and or weakness. If they have weakness on that side, obviously you can compare it to the other side and make sure it's weaker than the other side. It is just as sensitive and specific as an MRI. So please consider using the dime test. If you want videos of that, there'll be a QR code in the next couple slides. And I included the video for that so you guys can see. So the dime test is tremendous. Also a new test. This just came out in I think this is shoulder and elbow surgery, but it was this year, February, I believe, about the internal rotation and shift test. One thing that patients with rotator cuff syndrome and impingement syndrome don't like is internal rotation. If you force them into more internal rotation and it reproduces their pain, we're really looking for that supraspinatus or a biceps tendon. Now, keep in mind, we always think about a biceps tendon as not the shoulder, but the biceps tendon comes over the glenohumeral joint. That has a great mechanical pull down on the glenohumeral joint. Once again, preventing it from going and rubbing up on the things on top, though, that squishy stuff in the middle. So keep that in mind. And the next big topic we're going to talk about with the shoulder is tendinopathy. Just because someone has a pain or a problem doesn't mean we get to be nice to them. It doesn't mean we get to pat them on their back and we need to give them words of affirmation. Because the simple fact is most of our patients that have recurring pain have some sort of tendinopathy with tendinosis, meaning that tissue is becoming weaker and weaker and weaker due to the repetitive activity, the repetitive strain, the repetitive postures, what that person's doing. So can you use ice and rest for a little bit? Yeah, we need to calm things down. But when it comes to nearly every joint in the body, we our patients are going through a failed healing response, and in the shoulder specifically, that failed healing response leads to weakness. That's when the patient's not able to pick up their arm. They're starting to actually use their shoulder blade and the upper trap to help move their arm because they're getting that impingement that happens over and over and over again until eventually it tears. So people don't walk in your office with a rotator cuff tear. They've been working on that rotator cuff tear for 20 years. The question is where they're coming into your practice. We need to be able to assess them and treat them and prevent those things from happening in the future. So something to take in mind, we're going to talk about that also in the elbow in the next section, but identifying any kind of weakness would be tremendous for your patient. But here's the hardest part, that once that patient is out of pain in their shoulder, guess what I get to do with them? I need to give them hard exercises to build up that tissue strength, whether it's the glute, whether it's a supraspinatus, whether it's the infraspinatus, whatever muscle or whatever diagnosis you're treating, you need to now give them the right rehabilitation exercises. That's how we're going to build happy, satisfied, successful, and patients who are now reviewing you on Google. All those things are extremely important and lead for a result of coming up with the right diagnosis for the right patient. And if we can give the right evaluation, we can give them the right treatment. Here's something that, whenever I hear about nocturnal pain, nocturnal pain is a red flag until proven otherwise. However, here's something to consider, that if you have somebody with impingement syndrome, or you have somebody with rotator cuff syndrome, and that tissue is inflamed and trying to heal, which requires blood flow, and you're sleeping on your shoulder, that's a bad deal. That tissue is now going through ischemia. It's not able to heal. It's getting more inflamed. And now we have more pain at night. So just because someone has nighttime pain doesn't mean they have cancer. Still screen it out with your red flags for them. However, we need to make sure that we're looking at the way they sleep to see maybe that's the problem. Maybe it's the way you're sleeping is causing your problem. Here's, if you want to take a look at all the videos and also some forms as far as how to evaluate and treat the shoulder. You can scan this QR code. But think about this. If someone's sleeping with their arm above here on a pillow every night, it doesn't matter how good of a manipulator you are. It doesn't matter how good of exercise you give or your manual therapy or what you're certified in. They're creating their own problem. So digging through someone's life and really trying to find what's causing their problem is the beauty of the care that we provide. Once again, if you have any questions, we're going to answer those at the very end. So please put them in the chat thing. I can't see the questions right now, so otherwise I would answer them now. The elbow. So moving on, this is one of those diagnoses that, everybody thinks they have rotary cuff syndrome when they have a shoulder problem, and everybody thinks they have tennis elbow when they have an elbow pain. And most people, if they went through an activity and it caused a problem, they may have some inflammation. When you look at tennis elbow, they have inflammation or tenderness of that extensor carpi radialis brevis. This is the most common muscle that we're going to have torn, or at least some kind of pathology. And it's usually just off the bone. It's not on the bone, unless they're a little kid. Obviously, that'd be the biggest point in someone who has open growth plates. But it's going to be a little bit off that epicondyle. Now, if it's a little further down, it's creating numbness and tingling down in their hand, that's probably radial tunnel syndrome, so make sure we roll that out. However, this is commonly not a tendinitis. Once again, just like the shoulder, it's commonly mostly a tendinosis. So if somebody says they have elbow pain and it's a chronic tendinitis, that's an oxymoron. Could it get inflamed every once in a while when you do too much activity? Yes, but the underlying problem is probably degenerative tissue. So check it for weakness, and most importantly, give them the tools to rebuild that tissue. So instead of being nice to it and icing it and resting it and pulling them off of work, take a dull screwdriver, which we call Grafton and Factor and all the instrument system manipulation tools we use, and rub the living crap out of it. And I mean that lovingly to my patients. I need to create a controlled inflammatory reaction. And then I need to marry that to some eccentric exercise to help load that tissue up and build some strength within that tissue. I also can do things like some supplements, whether you use supplements or injections or what have you. you can also speed up the healing, provide the building blocks that get that tissue to heal. This paper, as another one, came out in March, I think. Yeah, March. But something you can buy over the counter to help get those tendons to heal a little bit faster. You can also do injections, dextrose sugar, or PRP. This is opinion, not fact. I've had limited results with PRP when it comes to as a whole. However, I've had very good with PRP injections for shoulders, elbows, and hands. So for some reason, with non-gravity bound tissues, I've had really good results with. When I've used it for ankles and knees and hips, I haven't had good results with. So I'm not saying that's not a scientific fact. That's just my pure opinion, but something to think about. Also, something to think about is stop wasting your time and your patient's time. Is that we're finding now that ultrasound therapy just isn't giving good results. So maybe if someone's very acute, it may be beneficial, but just because we have the machine in our office, I'm in my office, I have one back there, it doesn't mean that we have to do it in every single patient if it's not useful. So finding the right passive modalities that would help that patient are tremendous. Your extracorporeal shockwave therapy, doing dry needling, acupuncture, those are things that I do have a good amount of research on. We've got two more, I think it is. This is a big one. This is carpal tunnel syndrome. And I want to give you a tip that, once again, embarrassingly, I had no idea what was the case. And so carpal tunnel syndrome, I was always under the impression the first three digits of the hand. So we have a carpal tunnel, and in that structure, we have a bunch of tendons. I don't remember all the names of the tendons, but I know the nerve lives in there, and that nerve supplies the sensation to the hands. And due to that local ischemia, due to repetitive trauma, due to repetitive stress, we can get thickening of that capsule, and unfortunately some neurologic symptoms. But what we've learned is that tissue, that nerve, actually gets inflamed, starts to weep fluid, and creates some fibrosis around that. It becomes stuck. I like to think about it like a spot weld. And when you do surgery on that, you can help improve that. You can help take away that space. But even if you just do surgery, that nerve doesn't move any better. So you still have to do something, and that is neurodynamics. That just because you do carpal tunnel surgery and you release that compression, now is the best time to get somebody into doing nerve flossing exercise. In fact, I think I'll do it. I have a video here. So I think this is a tensioner. Yeah, this is a tensioner, not a flosser. However, taking and pulling at the median nerve. Now, if she were taking her head to the opposite side, so what this is as she pulls her hand back, she's tensioning that nerve. And if you were to go to the same side, you release the tension of that nerve. And then you can imagine that if you go to the opposite side, you're actually pulling the tension from that nerve. You're pulling from the head up. So nerve tensioners and nerve sliders are tremendous to help get the nerves moving. Just because someone has a surgery doesn't mean it'll flow out of your office. Just because someone has a surgery for carpal tunnel syndrome, now is the best time to come back in your office. Now, here's the number two thing that I learned. That if you look at the hand and you have numbness and tingling just in the fingers, that's carpal tunnel syndrome. If you have numbness and tingling actually in your palm, that's not carpal tunnel syndrome. If you have it in this area, there's a palmar branch to the median nerve that goes above the actual retinaculum. So if you're getting symptoms in this area, I'm not saying it's the pronator teres or the shoulder or the neck. It's just something upstream. Now, if it's all the area, you still need to address the carpal tunnel. It could be involved in that. However, if you get numbness and tingling in the palm of your hand, you're going to want to consider things upstream. And what we know with a lot of nerve symptoms, it's not just one site of compression. It could be multiple sites of compression. Most of our radiculopathies are double crushed spine and then something else peripheral. So something to at least consider with your patients that we think may just have carpal tunnel syndrome, but they're not responding to our care. Maybe if we can take a look upstream and see if there's something else going on. Running. So I, probably my favorite group of patients to treat are my runners. And there's a great book by Thomas. Well, obviously, he wrote the Bible on orthotics and orthoses with his textbook. But Injury-Free Running, it's a paperback book that Tom Michaud wrote. Just tremendous, going through how a clinician can easily work through diagnoses. I know he helped write our protocol on heel pad syndrome, He did another one he helped with, I think it was plantar fasciitis. Just a tremendous asset to the profession. If you ever have a chance to see him speak, he's tremendous. However, in his book, we steal a lot of our evaluations and treatments from because it's so good. It's really taking a simplistic look at how to assess someone and how to treat them with very simple exercises and strategies, I should say. I shouldn't always say just exercises. One thing that this isn't in the presentation, but some people focus on pronation of the foot, and the pronation is a natural thing, but it can lead to problems. That just slowing down pronation is not the function of an orthotic. The pronation is going to happen no matter what to the shoe. However, orthotics, we slow down the rate of pronation, and he's got put valgus posts in the forefoot of your foot, helps slow down pronation also, and doesn't require that arch support. I know for my athletes, they would have to wear cleats where they don't have a lot of room in their shoes. Using those posts can go a long way, and it's something you can do in your office. Once again, beyond the scope of this presentation, but might help you or your practice. Look for patterns with your patients. A pattern isn't, they have foot pain. A pattern is what they're doing to themselves. So if someone is a runner and they've had pain while running, we should go look at them run. I'm always intrigued by the patients who come in, they've seen multiple providers, and they come in to see me because they have a pain with running, and I want to take them outside and like, well, you're going to watch me run? Well, yeah, how are we going to find the problem if we don't see what you're doing? And the same with all of our evaluations, whether it's a shoulder or the hand, make sure you're doing orthopedic testing, functional testing to see where their deficits lie. But with the rear foot strike versus forefoot strike, this is a big deal. Now, the key topic I want to convey here is that people don't necessarily need to be rear foot strike or forefoot strike. They can switch back and forth. And when you have a rear foot strike, we're going to see a lot of overactivation of the quadriceps. And unfortunately, when we have that, we're really going to load the patellofemoral joint a lot. So your patients with knee pain, those are usually our slower runners and running on the bottom part of the foot of the heel. Our forefoot runners are going to start to load up some different parts. They're going to get more of their plantar fascia. They're going to get more of the hamstrings and definitely the Achilles tendon. So if you start to have a patient who's running and they have a characteristic problem, take a look at the way they're running. And maybe for a couple of weeks to months, we start to switch the way they run based on their pattern dysfunction. If you can just widen their stance out a little bit, increase step cadence, can significantly take away those ground reactive forces also. So looking at the different ways of running and having a plan with your patient. So if someone comes with Achilles tendinopathy, have the best evaluation, the best exercise for them. You can just relay that to them. Because if you can automate 98 to 99% of what you say and do in your practice, and you only have 15 minutes with the patient, it gives you those extra minutes to really drive down and drill down deep with those patients and find out what's causing their problem. Maybe it's not the running, and maybe it's because they're standing all day and they're a nurse, or maybe it's their job related activities. So we can really try to dig into their lives and find out what's causing their problem. And I think that's one of the lost arts, because technically we don't get necessarily paid to do that. Is start to dig deep and to find out what their hobbies and their sports and activities are. But the more we can do that, we can apply the right principle to treat them. For example, if we have plantar fasciitis, same principle as the shoulder, these aren't plantar fasciitis. They've been going on for 7 years. When I get a patient with plantar fasciitis, rarely do I have them and it just presented. And if it did just present, they've had it for the last 6 years, been kind of going up and down. Putting an orthotic in these patients, being nice to them, having them roll their foot on a frozen water bottle, you're just might as well just go pee in the wind. These patients need to get roughed up a little bit. So we need to create that controlled inflammatory reaction. And we need to help create that through instrument system manipulation, through dry needling. We need to do eccentric strengthening and stretching of the plantar fascia. We need to strengthen the intrinsic muscles of the feet. And that's not as easy. It's not as easy as just mobilizing the foot, manipulating the foot, and putting them in a Strasbourg sock and send them on their way. While those may be good to calm things down, it's not going to be what keeps that person out of pain. So making sure with each and every one of these diagnoses that you have a strategy to help get these people out of pain. And it's not, like I said, just one modality. It's selecting the right modality, the right treatment for the right patient. And when we can do that across the board, that's how we can take all of us, instead of comparing apples to oranges, when we all kind of do similar stuff, we're comparing apples to apples. And now we can market those apples to other people who want to eat apples, which are patients. Can you imagine if every patient that you treated, told Google about how great job you did, how many Google reviews would you have? Can you imagine if every single one of the patients that you released from your office, they went and told their medical doctor about how great of a job you did? We do that with our practice. We do an initial report, meaning, hey, Dr. Smith, I saw your patient. They have plantar fasciitis. I'm going to see them 6 times over the next 3 weeks. They're going to be 75% better. I'll send you a note when I'm done with them. Then guess what I do when I'm done with them? I say, hey, Dr. Smith, I saw them actually 8 times. They're back 100%. They're out of my care. Thanks for allowing me to participate in the care of your patient. When I started incorporating initial reports and release reports from my medical doctors, we had to hire an associate because all we do all day long in healthcare is trade each other's failures. Like epidural steroid injections. I see tons of patients come over here that epidural steroid injections it didn't work. Oh, it didn't work. They come see me. Of course, I'm conditioned to think that epidural steroid injections don't work. However, how many patients of yours and mine go back to pain management? Yeah, saw Dr. Steele 4 times, didn't work. All that pain management doctor hears all day long is how chiropractic doesn't work. All I hear all day long is how epidurals don't work. So we treat each other's failures all day long. One way we can combat that is to get better data from what we're doing. And we can also market how great of a job do we do. So please get as many Google reviews as you can. Please send out initial reports and release reports to medical doctors. That's something that takes 0 time out of my day. We have it all automated. And now we can it's free marketing. It's putting your name, your logo on the desk of a medical doctor on a daily basis, and they can see the results you get. Sorry, I got a little off topic there. Last section, Achilles tendinopathy. This is a different thought process. And there's a lot of different ways I could have gone with this talk to help provide a clinical pearl. But here's an interesting one, is that cholesterol issues, blood pressure issues, diabetes, thyroid disease, that's what's leading to a lot of our tendinopathies. So it's not the activity. In fact, 6 of the 7 risk factors for a rotator cuff tear are not musculoskeletal. They're total health status type things like cholesterol issues and high blood pressure. So it seems that maybe we should do things to help improve blood flow. So I don't do anything to treat cholesterol in my practice. Like I said, I'm not touching your diet. I'm not changing your medication. However, what can we do as conservative, non-pharmacological practitioners, non-surgical practitioners? We can get them to exercise. We can do what we're supposed to do. We can get them moving. And as it turns out, if we can help educate our patients, give them the right words of optimism, and being creative with their treatment plan, we can get them walking. We can get them running. We can get them walking around target. Those are the kind of things that we can do to help improve the daily lives of our patients. It's not being nice to them all the time. It's actually telling them what they need. And as it turns out, with a lot of our musculoskeletal conditions, it's not just MSK. While it's the vast majority of what I do in my practice, and I'm sure it's what you do in your practice, we can be doing other things that help these patients, whether it's a brace, whether it's exercise, whether it's manual therapy or nerve flossing. When you can start to select the right treatments for the right patients, we all as a profession benefit from that. For those of you who didn't get a chance to see it in the QR code, this will take you to a landing page and give you the access to those videos. And I want to once again thank you for participating in this webinar. I'm going to end about 10 minutes early to answer any questions. If you have any questions past the end of the seminar, Brandon, BRANDN @chiropractors.com, and I can answer those for you. All right, I'm going to pull back up the Q&A. Oh, here we go. Here's the question from Carrie Horn. Can we get my email again? It's Brandon @chiropractors.com. I think I answered that one right away. That's good. Any other questions from anyone in the group?
Well, thank you so much. Let's see, I'll give everybody a few minutes to pop in any questions. And then I just highlighted it in the chat box so y'all can copy and paste Dr. Steele's email address. Just a reminder there, and we've got quite a few really incredible speakers coming up for the rest of the year as we start planning and going into 2023. Any suggestions for speakers or topics that you would like to see on our weekly webinar series, please email me, Christy, at ChiroHealthUSA.com, so I can search out and book those people that you would like to hear from. Dr. Steele, I don't see any more questions in here. If you are watching this webinar presentation in the recording, just know that when you submit your questions through the chat box, they automatically email to me, and we will forward those over to Dr. Steele. She wrote, thanks, this was great. Wish my office still used your company. It was so beneficial.
Thanks, Carrie, for using it.
So again, any questions that you have, or if you're like me and you think about your question 30 minutes to an hour after the webinar is over, you can email myself or Dr. Steele, and we'll be happy to get an answer for you. Everybody have an amazing rest of your day. And